Good afternoon, and thank you for joining today's session entitled Weaving QI into Residency Education. My name is Denise De La Rosa, a marketer with BMJ Quality. I'm joining today from the BMJ office in Hoboken, New Jersey. I'm excited to present today's speaker, someone very well known in the quality space. Dr. Khemani is an assistant professor and anesthesiologist at Western University. She is the co-director for the Department of Anesthesia and Perioperative Medicine Fellowship in Quality Improvement. Since joining Western University, she has introduced a patient safety and quality improvement curriculum within the Department of Anesthesia and Perioperative Medicine, as well as introduced a postgraduate-wide seminar on adverse management. Dr. Khemani completed her residency at University of Toronto in 2014. Early on in her career, she completed a Master of Science at the Institute of Medical Sciences at U of T in 2005. In 2015, she completed a certificate in patient safety and quality management and recently won Best Poster and Presentation at the University of Calgary Patient Safety and Quality Improvement Research Day. Ekta has presented numerous papers and authored several publications. Dr. Khemani currently sits on the London Health Sciences Patient Experience Committee and is actively involved in the multiple hospital quality committees, which makes her the ideal presenter for today's session. Without further ado, I present Dr. Ekta Khemani. Good afternoon, doctor.
Thank you very much, Denise. Thank you very much for having me. I'm so excited for today's talk. Today's talk is Weaving Quality Improvement into Resident Education, something I feel very strongly and passionate about. So thank you for having me. So to begin, today we're going to be talking about the new reality. Gone are the days where residents simply need to discuss and talk about differential diagnosis and management. The new resident has to have instruction on quality improvement. As a part of residency education, it makes them higher learners. It's part of their core competencies for Canadian medical education, and I know this trend is happening all around the world, where we're asking residents to not only look at the diagnoses and the management, but also to look at the healthcare and evaluate as a whole for quality improvement. So most residents, when we're talking about residents and how they can get involved in quality improvement, we know is that most residents will experience at least one complication during residency. And when they have these complications, we need to move away from a culture of shame and blame. That's typically what happens when a resident faces an adverse event. And instead, what we need to do is we need to encourage adverse event reporting, because as we'll see through this talk, is that adverse event reporting is the foundation for developing quality improvement tools. We've all been there, we've all done that, but let's see what we can learn from this. And how can we turn this complication into a quality improvement project? Stuff happens, as I said. We must aim to each resident to describe why, how, and what complications to report, describe how to use systems-based analysis towards complications and understanding complications, again, getting away from the shame and blame culture, and describe how complications can actually lead to projects. So those are the objectives of today's talk, and hopefully I'm able to meet them all for you. So why should we report? Well, first of all, it seems obvious, but it does lead to better care for our patients. The more we know, the better care we can give. It alerts our colleagues about new hazards. We can look through the central trend of our hazards, and the information about the experience of individuals can be disseminated to prevent errors. Again, leading to the idea that we need to change culture. We are not alone when we face these adverse event management. This is what happens to all of us, and what can we learn from this? And actually, the central analysis of all these adverse events has led to many best practice guidelines. It's led to case reports on HIV and AIDS management. It's led to difficult airway algorithms. So these adverse event management and these adverse events that occur are actually great stepping stones for learning and improving, particularly in the quality improvement world and in changing our culture to one of safety. But what we see time and time again is although we know that we should report, we don't report. One of the quotes that I've had from one of my mentors is, the single greatest impediment to error prevention in the medical industry is that we punish people for making mistakes. Time and time again, it's a junior resident sitting in front of experienced physicians describing an adverse event only to feel ridiculed or only to feel that they're being blamed for something. Whereas that, as we know, is actually a great impediment. We're never going to learn. We're never going to prevent errors that way. We really need to change culture and encourage reporting. What we see in the literature is that in hospitals, staff members often fail to report incidents because of time pressure, fear of punishment, and lack of perceived benefit. With physicians, particularly residents, what we see is there's a fear of liability, loss of reputation, and peer disapproval are particularly strong characteristics. But this is why it's so important. When we look at the Swiss cheese model, we see that usually when an adverse event occurs, there's a number of holes within the system. And when you go through all those holes in the system, that's where you lead to your accident. But by reporting events and by discussing them and trying to figure out solutions through quality improvement models on how to prevent them, you're increasing your layer of defense so that you're not able to go through all those holes and that you're actually preventing errors and events from occurring. And we see this time and time again in the literature. We see this in the manufacturing industry where the near misses to actual events are 100 to 1. In the chemistry industry, we see the same thing. And when we looked at the medical industry, the exact same thing happens. It's always a ratio of 100 near misses to 1 adverse event. And it's those 100 near misses that lead to that Swiss cheese model that lead to the accident. And we really need to look at these near misses and build their layer of defense. Another favorite quote of mine is one by Reason that says, we cannot change the human condition, but we can change the conditions under which humans work. And that's the whole idea of coming up with successive layers of defenses through adverse event management and through teaching around adverse event management. So how do we get residents from identifying a complication to actually doing a quality improvement project? And what we see is what we're asking is the what, the why, the who, the where, and you're actually investigating the problem. So you're doing a higher order of thinking when you're engaging residents in this practice. An adverse event happens, and that's unfortunate. But the learning comes from, why did this happen? What did we learn from this? What are our institution's best practices, or what's out there in the literature, and how do we get from there? How do we get from our incident to the best practices? How can we do it so that this never happens again? And it really encourages a higher level of discussion. And you'd be surprised on what residents can tell you. Certainly when I've been working with residents in my own field and an event happens, I find that those are some of the richest discussions I have with residents because they often have a lot of insight onto why things happen like this and how we can improve it for next time. They're very motivated to do better. So this is an area that I really like to focus my time on in resident education and quality improvement. And again, that leads to introducing quality improvement into your curriculum. Because what you're doing is you're getting away from just understanding differential diagnoses and management and getting into an appreciation of the healthcare system, understanding the factors that are involved, the systems that are involved. And that leads to the psychology of who's involved in making these decisions at the systems. Who do they need to talk to? Who do they need to engage with, leading to an interprofessional collaboration to institute change. And that's actually known as Deming systems of profound knowledge. So we're getting outside of the textbook information and getting into higher information, higher learning with our residents. And that's how you bridge the gap, essentially, through education and practice. So education will give us the theory, but it's understanding the variation and the systems in the healthcare system that we live in and we work in, and the psychology behind it that actually leads to bridging the gap between theory and practice. So how do you help bridge the gap, right? You know you want to have a bunch of residents and you want to engage in this higher level of learning and the systems-based approach. But how do you actually get there? Well, there's actually a few tools that you can use to help, which I'll introduce you to. And it's actually about 3 steps, and oftentimes by going through these steps, you're able to get from an adverse event and some theory into a quality improvement project. So first of all, you need the guidance and motivation. And I'd say out of these two, I think the guidance is definitely where you need to play more of a role than motivation. Residents are often very motivated, especially when an adverse event occurs, to learn from it and to grow from it and to change. A lot of residents are very eager to change flaws that they see in the healthcare system or perceived flaws, but they just don't know how to go about it. So often, just with a little bit of guidance about this is who you can talk to, this is the system involved, they're very self-motivated and self-directed to helping improve the healthcare system. Because they really feel like they're part of something and that they've created meaningful change. And then comes the right tools. Now, there's a number of tools that you can use. There's the fishbone diagram for analyzing systems-based events. The Canadian Patient Safety Institute also has analysis. And of course, BMJ, through the quality platform, has a number of tools that you can use as well to break the gap and help them analyze an adverse event. Oftentimes, these adverse event analysis include more than just the incident itself. It looks at the people, the methods, the materials, environment, a number of factors. And by getting residents to look at the number of factors that are involved in a single problem, that's where you get that higher order of learning, the Deming system of profound knowledge that I was talking about. And finally, you need structure. Squire guidelines are one way. It gives residents the ability to look at what's required for quality improvement projects and to publishing it. What I find to be very helpful for my residents is putting them through the BMJ quality program, because it leads them step by step through a quality improvement process, basically. We start off with a problem base and a problem statement and its completed examples, and it takes them through all the steps, analyzing things through process maps, through PDSA cycles, all the way to a completed project, which they can then publish, and they feel a lot of pride in it in doing so. And so what can happen? What's the result of getting residents involved in quality improvement projects? So to give one example, and we have a few residents who are doing quality improvement projects, actually several that are doing it through the BMJ platform, is one of them is reducing inappropriate ESR testing with computerized decision support. And this actually came to me, this project actually came through a resident. One of our residents, she was PGY2. She was very frustrated because commonly she would get calls from the internal medicine floor saying an ESR test has occurred, and she didn't know whether to interpret the results in isolation. And we had a discussion because she said, you know, Dr. Khemani, I don't really understand why we're ordering all this ESR testing, and we don't really know what to do when we get the results. So I gave her a little bit of guidance and asked her to look through the Choosing Wisely program. And from there, we're able to look at the criteria for ordering ESR. And from that, we decided to do an educational bulletin and actually involve computerized decision support, because then we did a process map and we saw all the people that are involved in actually ordering an ESR test. And through that, we were able to analyze and find that it's actually computerized decision support that actually helps to order or negate us from ordering inappropriate tests, and we got them involved in that. And what we saw was when we sent out a bulletin, it didn't really change any of the ESR orders. But actually, when we involved computerized decision support, which when you see actually is CDS implementation, the number of ESR orders reduced significantly. So it really shows a benefit when they actually work with people, collaborating and looking at things from a system space, that you're actually seeing a big change in the number of ESR orders. And we did need to modify the order sets a little bit to include other groups, but there's been significantly less ESR orders as a result. And what's also very motivating is this resident was able to feel that she was involved in the process and that she helped create change within our hospital and our institution based on best practices. And that's what really incorporating quality improvement through resident education is about. So motivating residents to do QI, again, many of them are self-motivated. But basically what you're doing is just showing how a complication can turn into comprehensive, higher order learning, away from the textbook and into real medicine, and how they can create change. And that actually is very empowering for them. And then what they can find from this is they can find that their quality improvement work, well, that's just not only affecting institutions, but it could affect change globally by disseminating knowledges through publishing it. And information like the tools that the BMJ Quality actually provides really helps them provide a structure and gives them an opportunity to publish their work and feel like they're creating change not only at their institution, but perhaps in other institutions as well. Many of residents have to do a scholarly research project, and they find the quality improvement platform through BMJ very attractive because, like I said, it goes through all the completed examples. It gives them step-by-step ways on how to do everything. I can go log in and see their progress and guide them as a result. And then they're all set to publish right after. So it's been very gratifying for them and for myself to work with the tools here to lead them through a quality improvement project. So just talking about some of the things that strengthen my commitment to leading quality improvement into resident education is improving the culture of quality improvement, support by the C-suite, poster presentation, underlying that the value that comes from having residents tackle problems that they've experienced for themselves, and the ability to get them published early on. I first was introduced to the BMJ platform at a conference, and the conference was actually, I was just there to support my resident. My resident did all the work. My resident put up a poster at the IHI. She had experience by presenting at a national conference, and we were able to actually have a conversation about how her project created change and created discussion at a national conference. And from there, the information she presented was able to get published. And I can't tell you how satisfied this resident was, because we've essentially helped change the culture from taking an adverse incident as something that she would have typically felt very ashamed of into something very powerful and meaningful for her. So with that, I want to leave you with one question. How will you prepare your residents to improve quality and patient safety? Thank you very much.
Thank you, Dr. Khemani. I really appreciate you taking the time to speak with us today. Unfortunately, we don't have time to take questions, but everyone who joined today's session will receive Dr. Khemani's contact information and can send her questions directly. She is eager to continue to help others weave QI into residency education, and we are very pleased to have her presenting for us today. So thanks again. That was very helpful. We hope to have you speaking with us again soon, Dr. Khemani. Thank you.
Thank you very much. It was my pleasure.